welcome to my channel Pediatric Classes. Today we are going to discuss about the approach to short stature. It's a very requested video. You would have seen my previous videos on short stature. So if you have not yet subscribed to my channel, please do subscribe and click the bell icon to get the notifications on time. So about what is short stature, how to plot a short stature, and the details of it have already been discussed in the previous video, that is growth in children part 2 and part 3. So in this short video I would like to discuss how to approach a short stature in a very easy way. So short stature, as you all know, is height of the child less than 5th percentile or less than -2 standard deviation below the mean for age and sex of the child. Now we need to ask in the history certain things, and we also had to look for certain things in the examination. So in the history, definitely you will be asking a history of short stature in the family. Definitely you will be asked, we have to ask the history of delayed puberty in the family. You also need to ask whether the child had any recurrent diarrhea. Why you are asking history of recurrent diarrhea? That is to find out or rule out any malabsorption. Certain histories we need to ask. We need to ask the parents whether there is any history of short stature in the family, but about any history of delayed puberty in the family. Then we need to find out whether the child, how was the birth weight and the birth length of the child. If then any history of chronic diarrhea. Suppose it is a case of malabsorption leading on to a short stature, there will be history of chronic diarrhea, passing of fatty stools, etc. Then we need to also ask any history of polyuria to rule out a renal tubular acidosis and any kidney diseases. Then we need to ask about, we also need to ask in the neonatal period whether the child had any hypoglycemia, like neonatal hypoglycemia, which may actually a presenting feature in case of a hypopituitarism. Triad can have us neonatal hypoglycemia, micropenis and neonatal jaundice. So that we need to ask. See, so many histories can give you a clue to the diagnosis. If the patient is telling the baby was having lethargy or dry skin and all, you can consider a diagnosis of hypothyroidism as a cause of short stature. We need to ask about how much is the dietary intake of the child. Suppose it is an undernutrition which is leading on to a stunting also, then the child will definitely the intake will be very less. Also ask relevant history to rule out psychosocial dwarfism. That means all the relevant family support and other any issues in the family has to be asked clearly. Any intracranial space occupying lesion in the pituitary area, like for example a craniopharyngioma, can present you with headache or vomiting, etc. So that history also need to be asked. Once some histories are asked, then we need to go for specific examination. Thing is, we need to document the exact height of the child. We also need to find out the upper segment lower segment ratio. We need to find out the weight of the child, and if it's a small child, please document the mid-arm circumference also. Find out whether it is wasting, standing, or is it both. That is about the anthropometric data. We also need father's and the mother's height to calculate the mid-parental height. So how to calculate the mid-parental height, how to plot it, and all are discussed in detail in the part 2 growth, that is plotting on the growth charts, and part 2 and part 3 it has been discussed, but still I will just tell you once again, that is mid-parental height is father's height plus mother's height plus 13/2, whereas in boys, in girls it is father's height plus mother's height minus 13/2. Then in the child, why are we finding out the upper segment lower segment ratio is to find out whether there is any skeletal dysmorphism, whether if it is a dysmorphism is there, if it is an upper segment or short limb dysmorphism, or if it is a short trunk dysmorphism. We also need to calculate or find out whether, we also need to find out how the skin of the child, whether it is coarse. Then it may be a clue to hypothyroidism. Then we need to find out, we may get some clues for a chronic kidney disease associated with the chronic kidney disease from that. What are the clues? We may get hypertension in the child, we may see a pallor. This pallor can be seen even in case of chronic anemia leading on to short stature also. So once you see a pallor, you have to consider not only chronic kidney disease but also chronic. In case already discussed in hypopituitarism, you will be seeing a micropenis. You look for any frontal bossing. if there are any depressed nasal bridge, if there are any crowded teeth, etc., that will all give a clue to hypopituitarism. In case of chronic kidney disease, these things have been already discussed. Then in case of Cushing's disease, we will see a central obesity and also striae. So these are the things we have to look carefully or give us a clue towards the diagnosis of short stature. But what exactly is the approach? Let us discuss the approach to short stature. So don't get worried on seeing this big tabular column. I will try to make it as simple as that possible. It is very simple to come. So once you see the approach, see just first child has come, you have plotted and you have found that the height is less than the 5th centile or less than 2 standard deviation below the age and sex of the child. Then we have to ask the history of any pubertal delay or history of any family history of short stature, and then what you need to do is you need to find out the target height and also the mid parallel height and find out whether the child is following the growth curves. Then we need to do a bone age. Detailed video on the bone age will be coming up as the next video. So as of now we will do the bone age, and we have to divide this is the first visit, okay. So we don't have the growth velocity. If this is for NEET aspirants, in the growth velocity we have two things, that is familial short stature and a constitutional delay of growth. So the growth velocity is normal once the bone age is done, and if you get a family history of short stature and the bone age is equal to the chronological age and there is no delayed puberty, consider the diagnosis of familial short stature. If the bone age is less than the chronological age, but the bone age is correlating with the height age of the child, then and also if there is a history of delayed puberty, no history of short stature in the family, but there is history of delayed puberty in the family, yes, it is a case of constitutional growth delay. That is the most common cause of short stature in children. That was an MCQ which was asked a few years back in one of the entrances. So it was like the most common cause of short stature. It is constitutional delay of growth and puberty, that is CDGP. Okay, so that comes to one part. So if these histories are there and you are going to one side, and next to the other limb we are asking the history of any family history of short stature, nothing, no delayed puberty and all those things. So we are coming to the next limb of the right limb of the short stature. If we, for discussion purpose I am telling this. So what we need to find out is the weight for height ratio of the child, whether the child is thin or obese and all those things we have to find out. If once the weight for age is less than height for age, we need to consider two things. One is about the chronic systemic illness, another is related to the malnutrition and other things. Malnutrition, malabsorption or certain uncontrolled diabetes mellitus all can cause a less weight in the child. Similarly, chronic systemic illness which can actually cause stunting, it can include any system. So remember, if it is go in an order so that you don't miss out anything. So it is lungs, if you include cystic fibrosis, asthma. Then comes your cardiac disease, renal, it can be RTA, it can be renal nephrogenic diabetes insipidus, sickle cell anemia, thalassemias, then even psychosocial dwarfism can all lead on to short stature there. So now into the other limb what we have is, we are doing the weight for age, when you do the weight for height ratio, and also the weight for age is found to be more than the height. That means there what we need to consider is, we need to find out whether there, so if there is any dysmorphic features or there is any disproportionate short stature, that is, how do you know it? You do an upper segment lower segment ratio and it is abnormal. So that is actually disproportionate short stature. Please refer back to my previous video on growth in children, part 1. There you will get the details about all these things. So then you get an abnormality there, then you should consider syndromic causes as one of the causes of short stature, like for example Down syndrome, Turner syndrome, trisomy 13, trisomy 18, Prader-Willi, Cornelia-Leland, Lawrence-Day-Model syndrome, etc. Similarly, if you also need to consider skeletal dysplasias, that is like achondroplasia or osteogenesis imperfecta into the same limb of the approach. Also don't forget to consider RTA and psychosocial dwarfism again in that limb. RTA and rickets also can have a skeletal disproportionate short stature. So please note here, RTA we have read about it, where in the firstly the things which we have discussed previously also, in the disproportionate area also we have discussed. And once let us come to the next limb of it, that is when the weight for age is more than the height for age. When the weight for age is more than the height for age, consider endocrine causes as one of the causes of short stature. Like endocrine causes, like you all know, it is maybe hypopituitarism, it may be hypothyroidism, it is diabetes insipidus, diabetes mellitus, Cushing syndromes, precocious puberty, and rickets. Then other causes like RTA, psychosocial dwarfism also will come out there. So that is in short about the upper root. So if you just read through it, it is very simple. First, when the patient comes, plot everything and find out any history of any short stature or delayed puberty. If anything is there, you do a bone age and you find out whether it is a familial short stature or it is a constitutional growth delay. To the other limb, what is more important is a weight for height ratio, or the weight for age is more than the height for age. We find that means one limb, and when the weight is less than the height, if the weight is less than the height for age, we have mainly two or three things. That is, one is chronic systemic illness, another thing is malnutrition or the malabsorption related things, then RTA. Once their weight is more than the height for age, what we need to consider is, we need to consider endocrine causes as one of the major causes of it, and also RTAs and psychosocial dwarfism. That is the summary of what we have actually discussed. To the NEET aspirants, one of the questions is a very important topic. Please go through it and know it very clearly. One question which I saw in the recent papers is like, you all are aware that the bone age and the chronological age correlate in case of FSS, and the bone age is less than chronological age in constitutional delay of growth. You also need to know that the height age and the bone age is same in case of CDGP. Question was, what about the insulin growth factor levels? Please know that insulin growth factor levels and the bone age they correlate. So insulin growth factor and the bone age both are less than the chronological age in a case of constitutional delay of growth. The next video I will try to put up a few MCQs on short stature. Try to do it very nicely and try to revise it properly. The basic concept should be clear both for NEET aspirants and also for practicing pediatricians. And hope you have liked the session. If you are not subscribed to my channel, please do subscribe. Thank you and stay safe.